The next speaker is Beryl Benacerraf. Now, let me just tell you a couple of things about her, because she's a professor of radiology at Harvard, and she's one of these major figures in our specialty in fetal medicine. I want to remind you that she's the very first person that talked about the nuchal fold in the second trimester, that highlighted the importance of looking at the neck as a way of identifying babies with chromosomal and other abnormalities. And that was the beginning that then led on to the shift into the first trimester. So I'm very, very happy, Beryl, that you have agreed to talk to us. Beryl Benacerraf.
Thank you very much, Kipros. I'm thrilled to be part of this incredibly great group of people. And I was asked to spend 15 minutes talking about first trimester anomalies. I don't think I can do that in 15 minutes. And so I narrowed it down to choose anomalies of the face, which really reflects a lot of syndromes that we talk about that seem to have findings related to the fetal face. So first of all, as we look at the fetal face in the first trimester, and I think talking about the first trimester is so important because a lot of the prenatal diagnosis is moving into the first trimester, and that's where most of the money is as far as making these diagnoses. So in the first trimester, we can identify not only the nasal bone when we do our nuchal translucency, but we can also identify the palate, and we can identify the paired nasal bones, as you see here, and we can identify the maxillary triangle with the maxilla at the bottom and the paired nasal bones on top. And of course, we have our 3D to look at the surface of the fetus as well. Now, we have to understand the embryology when we look at the fetal face, because the upper lip is formed by the fusion of 4 different prominences, the 2 medial nasal prominences and the 2 lateral nasal prominences in blue that come together, and the 2 middle one come together and form the intramaxillary segment. And so most of the malformations come from the seam between the intramaxillary segment and the maxillary prominences. Some of the defects or some of the syndromes associated with facial clefts are listed here, and many of them are quite familiar to you. We just saw some great examples of VEC and of the short rib polydactyly syndromes, but you can see that when there is a complete bilateral cleft lip and palate, then the intramaxillary segment forms and the nose come together and they protrude, and they form a mass on the anterior portion of the face, which is very visible both on 2D and on 3D. Now, when rarely there is a big hole in the center of the face, as you see here, where the entire intermaxillary segment is missing. And this kind of clefting is the kind that we see in holoprosencephaly and in trisomy 13. You can see examples here at 14 weeks of hypotelorism, a big central cleft, no nose, and no real profile here, no nose protruding here at all, in this fetus who has trisomy 13 and holoprosencephaly. Now, somebody, one of our students, brought me this case to try and show me an attempt at the measurement of the nuchal translucency. But I said to this person, is the profile normal? And of course, I hadn't realized that it was not, because there was a big cleft right here. And you can see even the cleft in the middle of the maxilla. From here to there, there's a big hole right there. And as we looked into it a little further, of course, you can see that it's a bilateral cleft lip and palate. And you can see that because the 2 seams are off, that it makes a mass that protrudes anteriorly from the face. You can see here as well. So when you're lucky enough to have the fetus open its mouth, you can actually look into its mouth and see the cleft going all the way back, not only through the lip, but also through the entire palate. and you can see the failure of the palate to form in the front here. Now, there are other types of clefts. Tessier clefts are some of the most severe clefts. They occur, they're very, very rare. The type 4 and type 5 in particular are the ones that occur along the tear duct, along the side of the nose. They link the orbit, the floor of the orbit, to the mouth, as you can see here. This is a third trimester example, but we did see it in the first trimester. This is a first trimester example of a Tessier cleft, where you see that the cleft goes from the orbit into the mouth right here, with some micronaphia as well. And here it is, the cleft just on one side. Now, micronaphia is another uncommon finding in the fetus, and unfortunately, when we see this kind of macronaphia in the fetus, it tends to carry a poor prognosis, and it tends to be associated with one of these major syndromes here. As you can see, Joubert syndrome, for example, has micronaphia and Dandy-Walker abnormality. Nager syndrome is the one that also has the short radial ray associated with it. Many of you are familiar with these syndromes, so I don't have time to go through each one of them. But you can see that the chin is abnormal. And again, these patients all come in to get their nuchal translucencies or their first trimester evaluation, and this is a perfect time to look at the chin. Now, I tend not to measure as much as many other people. I will sort of look at it, and if it looks funny to me, I will look into it further. But you can see that 3D makes it even more obvious that there is a problem with the chin here. And sometimes the chin is practically non-existent, as you can see here, where there's just a total sort of missing portion of the mandible. So you can see very easily on this early fetus that the mandible is very small. This might be a little more subtle. You might worry about that maybe you're not at a good angle. Sometimes if you're off a little bit from the midline, you can make it look like that. But if you look at the mandible itself, you'll see normally there is a gap here. And when the gap is when there is micronaphia, the gap disappears. So there's a lack of mandibular gap right here. This is an example of ectrodactyly. We saw some beautiful pictures on the prior talk. This is often associated with facial abnormalities such as micronaphia. And here's an example of hypotelorism and holoprosencephaly, as you can see here, and hypotelorism here with the eyes too close together. The proboscis is up above the head, above the eyes, and we have a holoprosencephaly evidence right there. So these are eye abnormalities. We've moved on from the mandible to the eyes, and here again you can see how the eyes are too close together in this fetus who has trisomy 13, holoprosencephaly, and a big central cleft and hypotelorism. Hypertelorism, if the eyes are too far apart, on the other hand, that we see with triploidy and a number of other syndromes. This fetus clearly has triploidy. The head is too big, the body is too small, and that's a tip-off in the first trimester. And if you look at the frontal view of these fetuses, you can tell sort of the eyes are too far apart. They look elf-like in a sense. This is a 3D example. And if you look at how the eyes are far apart here, it looks like an elf in a sense. And it gives you the impression that in fact the eyes are too far apart. And in this case, you can see how the body is very small for the size of the head, in this case of triploidy. Now, amniotic bands can also disrupt the face. Here's an amniotic band that is disrupting the front of this face inside the head a little bit. And you can see here, we measured the mass. You can see the mass right here, and it actually protrudes from the face, and it destroys the front of the face. There was quite a bit of color in this mass. So it was a mass with excessive flow. Really could not see anything from the front here. And you can see the mass right there. this was growing from inside the head to the outside, to the front of the face. And this was an intracranial teratoma at 12 weeks, a very unusual case. Now, here was another case of a set of triplets, actually, but one of the fetuses had doubled the face. And so this was a severely conjoined twin set here with two spines. You can see the two spines, the two parts of the head. And if you look at the face, you can see that there's really three eyes, but the one in the middle doesn't show very well. And so you've got two eyes on the outside of this double face. And you can see here, as we scan through the face and the two spines. Now, I'm going to end with the most extraordinary case that I've ever seen. And it pertains to the face. This was somebody that came in, and this was an old case, a long time ago, for an elevated MS-AFP. Yes, that was way back when we used to do scans for elevated maternal serum AFP, and we found that the fetus did not have a head, and yet it was alive. It was moving around. It had club feet, but it did not have a head. And it wasn't that it was anencephalic. It absolutely did not have a head at all. No head, here are the clavicles, but nothing above that level. But the fetus was alive, the heart was beating, and the feet were clubbed. That was the only other finding. So obviously she underwent termination of pregnancy, and at termination, they found a little tiny head, an 11-week head that had been auto-amputated, probably by amniotic bands, and had somehow been preserved, and I guess the termination was done carefully enough to preserve the head and to show that this was terminated, that the head was amputated at a time earlier than the rest of the fetus was died. And that is my last slide. Thank you very much for your attention. And I'm going to stop sharing my screen right now. Thank you so much. And thank you, Kypros, for inviting me.
Wonderful presentation. Thank you. What a fantastic series of slides demonstrating your expertise. You know, Beryl, we have more than 15,000 registrations, 154 countries, and simultaneous translation to Portuguese, Spanish, and Russian. So I'm grateful to you. Ravi is there. I thought that Waldo had registered, but I haven't seen him. Waldo Sepulveda, who described the retronasal angle, and then Ravi with his gap. Do you want to give us a bit of comments on your gap, Ravi? It was a nice paper, but is it still useful or not really?
I don't have a gap. So brilliant, Beryl. It's always a pleasure to listen to you, and especially on first semester. This is the first time I hear you speaking on first semester anomalies, so I'm really, I love your book on syndromes. But on your setting, do you do a frontal view on routine, or you rely in the meantime also on the profile to seek for facial anomalies, or is it a combination of both as all of us are doing?
We do a combination of both. Our standard protocol is a frontal view and a side view, orbits, lip, and profile. And I want to thank Alfred, actually, because I actually borrowed some images from his book and on the first trimester, and I want to thank you, Alfred, for letting me borrow those.
Beryl, is Ravi's book also, so we did it together.
Yes, Ravi and Alfred, thank you so much.
Rasha, who is that?
You want to know about the measurement of the micronathia?
Differentiate between a micrognathia and a retrognathia?
Not very well. And I must say that I've always sort of thought of myself as a dysmorphologist rather than, I mean, I find that if I look critically at the anatomy in great detail, measuring is not going to help me that much, because if the measurement comes out not to be what I expect, then I tend to disregard the measurements. So I tend to really go with what things look like. And the measurements don't necessarily help me because the measurements is normal, but it still looks abnormal to me. I'm still going to call it abnormal. So I stopped measuring about 15 years ago.
Beryl, I agree with you. For Beryl Benacerraf, this is acceptable. But I think that if you are trying to train people and teach people, we have to measure. We have to measure.